skills, practice, barriers to evidence-based practice. Prior to her faculty position, Willa was the Vice President of Patient Care Systems in the Information System Department at Sharp Hospital Care in San Diego, California. She has had responsibility for the patient care computer systems, including implementation of new core clinical systems that include physician order entry. Willa has also published widely in the professional literature. She received her doctorate in nursing science from the University of San Diego and her master's of science in nursing from San Diego State University. She is currently serving as president-elect for the HIMSS Board of Directors, and I have the pleasure of introducing her presentation on transforming from a best of breed to a single vendor EHR with CPOE. Welcome.
Thanks, Leroy and the committee for inviting me here, and thanks, Ben, for your talk. Because in listening to what Ben had to say, I've completely revised the comments for my slides. So what I'm going to do is tell the story of the life of nurses in a community hospital as one conglomerate of computerized systems became extinct, and they are evolving into a one-vendor integrated solution. So, I mean, to put it into Darwin's theory is perfect. So the actual title of the research that I did is Transitioning from a Best of Breed, all of which will be extinct in other organizations and are extinct in our organization, moving to or evolving into a one-vendor integrated system with electronic provider order entry. I do want to recognize Sigma Theta Tau and Sharp Healthcare, who helped fund the research that I did. Are any of you in the audience researchers? Anybody in here participate in any research studies? Okay. My point with this slide is not only to recognize the team that I worked with, but one of the reasons our project was as successful as it was, both in the development of the study and then in the participation that we received from the nurses who took the surveys and allowed me to interview them, is that we were very, within a nursing world, multidisciplinary. So I came to it with the research background on the faculty. I was a known entity. I've worked with people at Sharp for many years, but I had internal people also, which gave me access, and then as a researcher, established that trust that I needed, that people would actually pay attention to the study and do it. So we had the chief operating officer, the chief nursing officer. We had the nurse informaticist at the local hospital. For many of the, several of the people in the study, they had no research background at all, but they had content expertise and they understood the user. And so it was, if we wanted to know what was the story from a nurse's perspective of going from this best of breed disorganized system to so that we can learn to make it better for future generations, we really not only had to have a broad section of the nurses, but within the research team, we needed to have people that represented them. So any of you that are asked to participate in a research study, I really encourage you to do that, because it's because of the participants in my study, from the design and the interpretation of the findings. It's a stronger study because of the people in the team. So that's just a little paid political advertisement. Now, Charles and Lisa, will they be getting copies of these slides? Will
Yes,
these
they'll be available on the website.
Okay, good. So the slides will be electronically available, because some of the information I may not spend that much time on, but it was information I wanted you to have access to. So what I really want you to get out of this is to be able to really see what are the nurses' views when going from a best of breed to a single vendor. If nothing else, all of you at some point in your career will experience going from one clinical information system to another. There are very few people in Southern California that are on paper. Most of the research has been done going from paper to electronic, but all of us are experiencing or will experience going from one computer system to another computer system And it is different from going from paper to computer. I'm a believer that it is harder to go from computer to computer than it is from paper to computer, because the benefits, the immediate benefit to the user is not as great. And then by understanding, for those of us that are in the early people going from computer to computer, hopefully we can learn from our experiences so the rest of you will be able to do it better than we did. So this is as I might say, a rather typical outline for the presentation. I'll give you a little bit of background, which all of you probably know, and then I'm going to talk about the survey results, the interview results, and really what are the implications for nursing practice. And it's nursing practice because we focused this study on nurses. So a little bit about the hospital. It's Sharp Grossmont Hospital in San Diego County. It's an urban hospital that also serves a rural population. So it's on the very eastern edge of San Diego. It's for California, a large hospital with 536 beds. It's a very proud hospital. It gives, I believe, excellent care. It's magnet designated, part of the Sharp healthcare system, which in 2007 was awarded the Malcolm Baldrige Award. So it's a very progressive healthcare integrated delivery system in San Diego County. It has been computerized since the late 80s, early 90s. And like many of your organizations that started on this computerized world early on, the billing system was picked by the financial people. The emergency system was picked by the ED physicians and nurses. The critical care system was picked by the critical care people. And so we really have these really good siloed systems that don't talk to each other. You know, I have it listed here. And through an earlier pilot with computerized physician order entry about 5 or 8 years ago, what was discovered was the nurses used the nursing systems, and they were very happy with the system that they had. The ED was very happy with the system that they had. When the physicians started the pilot of computerized provider order entry, they were very unhappy because they couldn't see all the information. It's just the presentation before me. You know, it's all the clicking, everything was not in any one system. But if you went through about half a dozen different systems, you could get everything. And the IS department did a really good job with desktop integration, and we used the CCAL standards, and you know, it was just all you had to do was click here or click there, but it was very disconcerting to the physicians. And in an sister hospital, the pilot on CPOE failed because we had too many different systems, which then highlighted for the organization that if we were going to be successful, we had to evolve to a one vendor solution, because even with CCAL and even with the tools that provided, going from application to application did not serve the user's workflow. Sharp Grossmont Hospital is, as I said, part of the Sharp healthcare system, and it was the 5th of the 6 or 7 hospitals to go live. So Grossmont was not the first one. I actually did a similar study, which I presented here in 2009 at the first Nursing Informatics Symposium, on the research that we had done at Sharp after the CPOE go live. But this is a talk about Grossmont. We were building on the experiences of the other hospitals. It was the largest hospital, and therefore there were some new complexities in it. But those of you that are in IT know that it's a lot easier from an IT perspective to go big bang. So on October 3rd, 2010, the switch was turned on, and we changed radiology, order entry, pharmacy, laboratory, ED, I'm going to read all these, documentation, HIM, from totally different systems to one. There was anticipated to be, and the reality was true, or realized itself, there was chaos. Okay? Have any of you gone through this big of a change? I fortunately was no longer working in IS. I had already a couple years before made my change and went to the university. It's much nicer to study the effects than to live the effects. I've been where you are. So I just give you a little background about the go live. Because this was an enterprise system, the physicians at Grossmont created a validation team to validate the approximately 200 order sets prior to go live. How many of you participate in a multi-hospital system? You know, my hospital is the best hospital, isn't it? And those other hospitals really don't understand our workflow and clearly aren't as good as we are. Now, I had the fortunate experience of having actually worked at different hospitals within Sharp, so it just depends which hospital I'm in. I can take on the persona of that hospital. But the physicians were skeptical at Grossmont. Did the other hospitals that had already gone live, do they really represent evidence-based practice? Because only I practice the best evidence-based practice. Now, the training for physicians was kind of interesting. It was voluntary. The Medical Executive Committee did not mandate that they had to have training before getting a user word and password. You know, you may say, how could you do that? It's not safe. You know, this is a political decision and it's a realistic one. You can mandate education and not everybody comes. So let's just call it what it is. It was strongly encouraged. The high volume users were personally contacted. Any type of education that they want was provided, meaning one-on-one, just in time, ahead of time, repeat education in a classroom. It's no longer, can I say we, the organization bent over backwards to give the education. It was 4 hours for most of the physicians. OBGYN docs had 6 hours because they were also doing some progress notes and other things that the rest of the hospital wasn't. The nurses, because they're employees, they had to go for education. So for an October go live, because there were about 3,000 people to be trained altogether, and there were 1,625 nurses, so we couldn't do the ideal, which is to do the education 2 to 3 weeks before go live, because that's just not possible. So the education started in June. And it was about 16 hours of education. 8 hours was how-to, and about 8 hours was on workflow. What we had learned from the research we did at the first hospital go live, that we had taught the how-to, but we didn't teach the process enough, you know, the change. It's hard to go from computer to computer. So why are we moving towards this? This is an audience I really don't have to go through all of these. You know that there's public and private organizations in the government, current president or previous presidents, reports from the Institute of Medicine, CPOE, electronic health records certainly have the promise of improving the health of the public within the United States. The literature that I actually want to highlight are 3 what are called systematic reviews of the literature. These are studies of studies. So in these 3 different studies, they looked at all of the research on electronic health records and computerized provider order entry to try to identify what have we learned, what can we say about them. So in the first study, which looked at published research from 1995 to 2004, what they found out was that the only evidence about electronic health records and CPOE, that when you implement them, you have better adherence to guidelines of care, but they really could not demonstrate the care improved. They just know that you followed, the people who used these systems followed the process. We had better surveillance and monitoring, and there was a decrease in medication errors. But they couldn't relate that to any improved outcomes. Then it was I found it kind of disappointing. From 2004, the research in 2004 to 2007, there was a lot of activity going on, a lot of patient-focused applications being implemented, but there was very little formal evaluation. Without the formal evaluation, we really don't know where we need to go, where the problems are. It was very encouraging this past fall. It's actually the same group that did the 2004 to 2007 studies looked at the next generation, 2007 to 2010, this is the most promising results we've had to date about the effect of electronic health records on patient care. What they found was 92% of the studies reached positive outcomes. Now, what Dr. Cantor had said is, the users find that one thing that is wrong and it causes this whole cascade of events. What gets reported in the cry are those 8% of the studies that didn't show positive results. I want you to know 90% of the research between 2007 and 2010 demonstrated positive patient outcomes. The last bullet should be of absolutely no surprise to anyone. Dissatisfaction with EHRs remains a problem and a barrier to achieving the potential of health IT. Duh. And that's, we haven't evolved to where we need to go. I was able to find one study that actually looked at going from a computer system to a computer system. And it was kind of interesting because they compared the changes paper to computer and computer to computer. And they found that the priorities are different. And when you're going from computer to computer, it's really about training, support, protection of patient privacy, and recognition of the resistance and the loyalty. The loyalty, do not underestimate the loyalty to the good old days. That old, soon to be extinct system was the best thing you ever had. Remember that. Most of the research, or a lot of research has been done on electronic health records, computerized provider order entry, and because computerized provider order entry is generally used by physicians, a lot of the research has been done on physicians. There hasn't been as much done by nursing. And what I bulleted out here are some of the results of the effect on nursing. There's a change in communication patterns, and you're going to see this in our results. Nurses very much fear missing orders. There's less time and collaboration with physicians. And this one study found that it wasn't used as effectively as the EHRs could be with handoffs, the workflow integration, and again, the evolution with build the tools that will be of benefit to the users, have the users involved with the support of the engineers, and some of the other things. So if we look at all of the research that's been done, we really need to study more that transition from legacy systems, disparate systems, best of breed systems, whatever you want to call it, to the integrated system, because we have to go in that direction. We're getting there. And then what is the impact on nurses and nurses' work? Since nurses are the ones who are at the bedside, as we all know, 24 hours a day, and how does this affect them so we can then mitigate some of the problems so that we can give safe patient care? So I had two overall research questions. We were interested on what was the nurse's view of the use, quality, and satisfaction of both the legacy systems and then the new system. We didn't want to ask them after the new system was implemented what they thought of the old system. We asked them while they were using the new system to evaluate it. And then we wanted to know, okay, what is the effect of transitioning from this disparate system that I know you're going to love more than you did at the time to going to this new one? So how did we do this? We did surveys 3 months before go live, and it was before the training started. Some of the super users had had training, but the masses of nurses had not yet had training. We wanted to get as good a picture as we could of the as is. So 2 to 3 months before go live, we used a survey, which I've referenced, and if you're interested, you can get the reference. It's publicly available, the tool that we used. And then we waited an entire year because we wanted to wait until the dust settled, because we knew it would be a tough transition. So we did the 2 surveys, and then from a research perspective, when you do surveys, you get a broad brush perspective, a point in time, but there's no depth to the information. There's nothing actionable. And that's why we also did interviews, because we wanted to hear firsthand the nurses' stories. And so we did interviews in that ugly stage, 1 to 3 months post go live, when they were in the throes of the transition. Because there's very little research done then, because everybody kind of knows. But we wanted to really look at that, because that's when our patients are at most risk for terrible things happening to them. And then we wanted to wait till the dust settled, and we did interviews again, 12 to 14 months. Now, I'm only going to be reporting on the first 3 parts, the 2 surveys and the first set of interviews, because we've completed the second set of interviews, and we're in the middle of analyzing the data, but that work's not done. So the result, just to paint a picture of who the people were, you can see that pre and post survey, we had about a 50% response rate, which was really good. There were no differences pre and post between males and females. Ages, you can see that the average age of nurses working in hospitals in the United States today is in the mid to late 40s. We have a slightly younger nursing staff that responded. They were around 40 years old. And the only differences between the 2 samples is, for some unknown reason, in the second survey, the nurses had been working as nurses a little bit less. So in the first survey, they'd been working as a nurse for about 14 years, and that dropped down to 11. I think it was just who decided to participate. Again, when you look at who the nurses are, it's pretty typical. About their initial nursing degree reflects pretty much what's going on in the United States. Almost half are associate degree nurses, and about half started out as baccalaureate nurses. And as the country is moving for nurses to become more educated, you can see that over half the nurses have their baccalaureate, and the organization does have an increasing number of master's and doctoral nurses. We got a pretty good representation of the different areas, but you can see 75% almost of the nurses who responded to the survey were clinical nurses working at the bedside. That's who we wanted. We wanted to really hear from them. And I was really pleased that we had a good representation between day shift and night shift. This type of response rate, 50%, covering all areas of nursing, day and night, was a tribute to the people who were on the research team and their level of respect from the nurses, and the nurses wanting to participate. This is kind of interesting, pre and post survey. We did want to know how many of the people responding were bought into the new system and were part of the design team, and how many of them had previous experience with CPOR or had worked with the vendor before. And you see the only thing where there was a change was previous experience with CPOE. For some reason, remember it was younger nurses in the second time, and 53% of them had had previous experience with CPOE. Now, this is where the rubber meets the road. So we asked about use, quality, and satisfaction. So what this table is, and if you're really interested in the detail of the results, please download the slides. What I've done is, these are the items that we asked them, and these are just how you use the system, and this really goes along with the evolution. So when we look at the old system and the new system, they're using it about the same amount for writing the care plans, entering the care notes, capturing patient observations. Those nursing things that nurses do and use the system. That did not change from the old system to the new system. But look at this, all of these items are statistically significant, and they went from 79% to 89, 75 to 86, they went up. So what we found was the nurses were reviewing the patient problems more because the data were available. They were obtaining information on procedures through the computer. They were obtaining results from new tests. They were answering medical questions. They were obtaining test results, checking drug information. The Cardex was a better Cardex. They were collecting information for discharge reports. They were documenting the physical assessment. They were using the new system more. So let's just stop, take a deep breath and say, wow, isn't this great? But we also looked at what they thought about the quality and how satisfied they were with the new system. That wasn't quite as good. In fact, the administrators who were on the research team went, ooh. So they liked the old system. They liked sort of the new system. Provides update information, precise information, meets your information needs. It didn't change statistically. You know, it really didn't. But let's look at this, especially in context of the previous presentation. Provides sufficient, oops, how often is the system accurate? They didn't, it actually went up. Satisfaction. Okay, so if the system is more accurate, but the satisfaction went down, that doesn't make sense until you look at this interview results. Output presented in a useful format. How does this go along with your talk? Well, so the accuracy's better, I'm not as satisfied, and I don't like the way it's presented. It's not clear, it isn't as user-friendly. And because it isn't clear, you know, getting the information I need in time is difficult. That went down. Downtime was a problem. And then there were some, initially we had some problems with some system crashes. The take-home message here is, although the nurses are using the system more, they don't like it. And it makes no difference who the vendor is. You know, this is vendor agnostic. So let's look at, should be no surprise with satisfaction. All of the satisfaction results were statistically significant, meaning that something happened, things were different, and they were not as satisfied. They're not as satisfied with its usefulness. Their performance, they said, has not improved. The quality of the work has not improved. The time and effort, and you'll see this in the interviews, everything. Really, to anybody working in IT or who has lived through and go live, this just validates what you already know. It's really important to do these studies because now what do we do with it? You know, you knew it. We now have evidence to say this is real. So what are we going to do? So I've said this really. So this is where the interviews come in. So these are the questions that we asked. And these are the same questions, basically the same questions I had asked in the previous study. I personally interviewed all of the nurses, and then it was the team independently went through the interviews, picked the themes, and then we got together to come up with what the themes were. And it really helped having these different views looking at it. So just, you know, open-ended questions. How would you view the transition? You could probably imagine how they answered that. How's your role changed? We're looking for workflow here. What impact has it had on you? What about communication? Because it's a whole different way of communicating with other clinicians and other departments. And how does the new system compare with the previous one? Demographics are pretty similar to what we had with the surveys. Now with qualitative research, interview research, you don't go for large numbers, you go for what's called data saturation. When I probably hit what's called data saturation after about 28 nurses. That meant at 28 nurses, I was getting the same, I wasn't getting anything new. There were people who wanted to talk to me. I had no trouble getting nurses to volunteer for this because I just sent out an email and let me tell you, they came to me. You know, like somebody wants to listen to me. And so I had no problems at all on this. And you can see, you know, with the demographics, pretty similar to what we had before. Across a lot of the clinical units, they just came to me. We did have more on the day shift, but there were night nurses who met me at 7:30 in the morning and stayed on after their 12-hour shift to tell me their story. I mean, if for no other reason they felt valued that somebody was listening to them. And they were, cross-section of positions. So what did we learn? Emotions. This is a very emotional experience. Some of the interviewees actually cried when they talked to me. Yeah, now, the emotions were both positive and negative. There were some good things out of this. Communication and relationships, training and education, system design and process change, and safety. And with qualitative research, some of these overlap, but these were the final themes that we felt came out of those 30 plus interviews. So let me go into a little detail. The emotions. They were worried. They felt very supported. There were meltdowns. It was stressful. Guilt, chaos. None of these words, for anybody who's lived through an upgrade, lived through a major computer change, none of these should be new to you. So let me just go through some of them. 4 to 1, negative to positive, but I have to point out it's not all bad. And as clinicians, as a nurse, I had to watch myself because all I really wanted to report were the negative comments, because that's what we learn from. The positive comments we don't learn as much, but I really have to be true to the data that I gathered. And so the subcategories are listed here, and I'm going to go to each one individually. There was a lot of angst about people's jobs. The nurses were very worried about the unit clerks. Yeah, see, they were really worried. It says, so their jobs are really the ones that take the biggest transition. Nurses are very caring people. They were worried about others. I didn't want to point out to this nurse that her job changed a lot too. But she's worried about the unit clerk because so much of what they had done was order entry. So take heed of this as you go forward. Maybe you are going to eliminate unit clerk positions. I can tell you in all of the organizations at Sharp Healthcare, there were no unit clerk positions lost. There were other things that their expertise could be used for. Fear was resounding. Fear of missing an order, fear of making a mistake, fear of causing harm to a patient. Read that second bullet. I'm really afraid that I'm going to make a mistake. Remember, this is 1 to 3 months post-go live, so they really haven't mastered the system. I've been a nurse for 43 years and I've had a stellar career. I've never been in trouble for anything, and I fear being in trouble with this system. That really represents that massive change. I don't want to cause anybody harm. It really, as a nurse, I found it very heartwarming how committed to patient safety the nurses were and how fearful they were. And so as people, some of you in the audience who are either designing the systems or you're supporting the nurses as they go through this, you need to recognize that fear and have the supports in place so that they can give the excellent care that they want to give, that they're used to giving. This goes with the talk before mine. It's harder to find it in the new system. Now, the quote I'm going to give you actually came from the second set of interviews, but I think it's appropriate for this one. What this one nurse said to me was, I knew how to, I used to speak in XYZ, that was the old system. I understood it. Now I'm in this new system, I don't know how to talk it. I don't know, it totally changed that worldview. You know how your hand just knows where to go and you don't have to think? Well, their hand kept going to where it was in the old system. And they didn't know how, they had to read the computer screen before they clicked on something, where in the past they could just click. So it really slowed them down. And they hated all the clicking. In the old system, they actually had more data per screen. And so that was really hard. And it is made for a lot of little meltdowns on the unit and a couple meltdowns in the interview. So they were nervous, they were stressed, they worried about missing orders. Now, it's a computerized system. They certainly had alerts. There were ways that the nurses were being told that there were new orders, but the nurses hadn't yet learned to trust the system. And so they would check and recheck and didn't trust it. And so that's another thing as you go live to realize that the system's going to have to prove itself just like humans have to prove themselves when it's something new. They worried and worried and worried that orders would get missed, and let me tell you, orders did get missed. You know, bad things did happen to patients, and people felt terrible about it, and therefore even an insignificant thing that had the potential to be bad really caused them to slow down. But it wasn't all bad. Let's see. I think I want to just close this. Okay. They could see that they were getting more proficient. And when things went right, they loved it. Because if you remember from the surveys, the use data, they were using it for more things, and they could see that light at the end of the tunnel. And they believed overall that they were still giving good care, and they really thought that initial period went well. And the reason the initial period went well is because they were told it was going to be really, 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 really hard. And so they were prepared for it being worse than in reality it was, but that doesn't mean that they were happy with it. So let's look at communications. What I'm realizing through this transition is when I said communication, the nurses responded about voice-to-voice communication. They hadn't yet understood that communicating through the electronic health record was communicating. And I think we need to point that out because they missed the physicians. I used to talk to the doctors. They're not talking to me anymore. You know, it's face-to-face contact is going out of the way. And it was nice before, if they were on the unit talking with us and they would write orders, they would talk to us more. The nurses felt they were part of the team. And now with remote order entry, which is a wonderful tool for the physicians, was really difficult for the nurses. And so as you focus on the physicians with remote order entry, remember that they never used to do it that way. And what controls do you have in place, supports do you have in place for the nurses who need to understand that order? Now, I love having everything together. The nurses love CPOE. Doctors put in their orders. I like that. I like that you can look at labs immediately. You can look at x-rays. It's all integrated. That goes to that use. And that goes to what you talked about earlier with the having the information. They loved it. It's legible. You don't have to call people as much. So there's definitely, they really saw the benefit. As much as they loved that old system, they did see some benefits. And they were starting to use it for handoffs. So when they gave reported change of shift or when a patient got transferred, transfer was beautiful because most patients get admitted to the hospital from the emergency department. Previously, the emergency department system was different from the inpatient system. And so the nurses on the floors or the nurses in the ICU couldn't look at the screen. And even if they could look at the screen, they weren't used to using the ED system, so it was foreign to them. Now everybody was on the same system, and so everybody could look at the same computer. It was right there. That was really good. Let me spend a couple minutes on training and education. At Grossmont, they had improved the education from the early hospitals because of results from some studies saying that not just how do you do it, but what about the workflow, and so that process changed. So there were improvements made, but we still didn't hit the mark. The training, these were some of the key points. The trainers were not clinical. Education wasn't customized. I'm going to go into each of these a little bit more individually. The trainers were experts in the system and technically were superb. Because of finances, they were not clinical. There were very few, if any, nurses who actually taught the system. When they did the how-to, it was all by computer trainers, non-clinical, really knew the system. When they got to the workflow, they had proctors in the room that were nurses for the nurses, respiratory therapists for the respiratory therapists. But they were not the ones teaching it. And the nurses wanted to be taught by nurses because they wanted people who understood the system from a nursing perspective. And so that was a major problem. And just to fast forward, the hospital then did do supplemental education with nurses to, because of the results of the initial results from the study. So that was really clear. The education wasn't customized. Again, for cost reasons, it was a nursing class. So there was somebody from rehab, acute care, critical care, ED, everybody in the same class, because isn't a nurse is a nurse is a nurse? No. And it would have been a scheduling nightmare, but probably should have been done to have ICU classes, rehab classes, acute care classes. Again, it was financially driven, and the problem was that the workflows in these different units were different. So if you can do it, the ideal, based on our results, is to have the training done by a clinical person of that discipline and to have like people in like rooms, or at the same time. I remember when I was in IT, I don't know what you do about this one. Training environment was not reliable or current. It's an evolving system. And the training environment was the last one to get upgraded. And you can't have people, I couldn't, when I got the data, when people gave me the answers, I couldn't give them the justification for why it was the way it was. I merely said, and listened to them. I don't know how you solve this one other than the training environment probably needs to be a higher priority in the IT department than it currently is. And I've never worked in an organization where the training environment was equal to the testing environment. This is all pre-go live, but training was always secondary, and it drove the nurses nuts that what they practiced on, what they were taught on, was different from what happened at go live. They wanted the go live system at the training. Well, I know from working in IT that you're working on that go live system until a couple days before you go live, because somebody played on it and found a flaw, and you're quickly trying to fix it. So do you just have a flawed system go live so that it's the one that they were taught on? Well, no, we want to help, and you know what I'm saying. So it is problematic. The other thing that I thought was kind of interesting, although the nurses wanted only nurses in the classes to be taught by nurses and for the nurses to be from only their level of care, acute care, critical care, they did feel that they never learned the global system. So they never learned respiratory therapy, the physician, they wanted to get that sort of gestalt. I bet you they were taught the gestalt, but they were so overwhelmed with the changes they never heard it. That's my guess, but what they told me was they didn't get it. What the organization did really well was the go live support. And to a person, everybody felt that it was excellent. They were prepared for chaos, and it wasn't as much chaos as they expected, which is always a good thing. There were lots of support, and I'll talk a little bit more about that in the end. Talk a lot about the way the system was designed and the process changes. They loved having everything in one system because for the first time, they could really get a comprehensive view of the patient. In the previous system, each application had most of the data, but no one application had all of the data. And now they knew that everything was right there. Order management. There was a lot of concern about, did a new order come in? And there was really, you can see down here, I have remote order entry. How did this happen? They never saw the doc. Did the doc really see the patient? Is it the right patient? Some hospitals have put into place processes when a physician does a remote order entry, they're to call the unit. Well, that's a clunky workflow. We got to come up with a more creative way from that, but understand that with remote order entry, it kind of spooks the nurse. Why is this lab person coming up to draw something? These are surprises. I didn't know anything about that. The nurse is the coordinator of care. And how can the nurse coordinate the care for the patient when there are these surprises? So how can, through the vendor, through the design of the system, through the communication patterns, how do we evolve, I'm going to use some of your work, for remote order entry, which is a definite benefit to the providers that are doing those orders. Med reconciliation, no place that I know of has figured out how to solve med reconciliation. This hospital has actually made it the physician's responsibility. And what the physicians are doing is writing what they call communication order so that the nurse can then help them do it. You see, I don't care which discipline you come from. We're all smart, we're all clever, and we all figure out ways to do things that serve us. And I thought this one was interesting. There's no way to double check an order. Well, that's actually not true. What the nurse really was saying was, I felt very comfortable looking at the computer order, because they did have computerized orders previously, but it was a paper chart. Physician wrote it in the paper, word clerk transcribed it into the computer, and the nurse checked the computer against the paper, and the nurse felt comfortable. Now, the physician puts it in the order, so it's an electronic order. Now, the nurse can check that order, but the nurse doesn't trust the order, and this was especially true in the beginning. So these are things we need to think about to anticipate to help in that training so that they're prepared for these changes. You know, the order is kind of like it just happens. And the whole discharge process, they found it really frustrating. The workflow didn't support the nursing flow. There were all these pieces. It was cumbersome, all these clicks. I see heads nodding up and down. You know, this process is going to have to change. And then safety. Safety was another really key piece. They felt computerized. I actually like the way they're putting in their own orders. A lot of them write in Braille. And there were med orders just because they scribbled and none of us could read it. And that is true. Now we have one. You notice that word kept coming up. We have an integrated system. They really valued having that one vendor solution. And they felt it did provide safer patient care. But they did fear making a mistake. And they know that they had caught themselves with potential mistakes, which they made them even more fearful that there were mistakes that they hadn't found. And so we need to increase the surveillance of, are there mistakes happening? What processes can we put in place to mitigate these mistakes if they, so that we don't have them? And then in the beginning, it was really unfortunate. There were some downtimes, and they feel very vulnerable with downtime. I thought this was a good one. I just want to read it. I think sometimes the patients are more at risk now because things are getting missed and things are not right. Remember, this is 1 to 3 months post go live. We're all on this learning curve and we're all trying to figure it out. But I think right now, I don't think I would want to be a patient. Would any of you want to be a patient? And so if we wouldn't want to be a patient in our organization, which we believe gives excellent care, what can we do so that we would want to be in that hospital during the go live? So even the system that we have now has to become extinct because we need better systems. So they're using the system more, the nurses. They really love CPOE, that they are not as satisfied as they would like to be. They fear making a mistake. They fear missing an order. They find the system harder to use, although there's more information. It's all these clicks, all these different views. It's very frustrating, and they're learning new ways to communicate. They miss the old ways of face-to-face or voice-to-voice. So what's the implications? First of all, do not underestimate the disruption. Change, we all know this, but let me just tell you once again, change is tough. And it's harder, I'm convinced, of going from a computer system to a computer system because of the synapses in our brain. My recommendation to those of you that work in hospitals, train, train, and train. And when you think you've trained enough, train a little more. Do not cut the training budget. Think, who do you want the trainers to be and what will best serve patient safety, because that's what we're all about. Even though you train, you need to provide practice. Make sure that training environment is as up to date as you can feasibly make it. Offer opportunities after the training for practice, because I can only speak for the nurses here, they want to do well. They don't want to make mistakes. They want to master the system before go live. It's really important for leadership, commitment, and visibility. The CEO, the CNO, the COO of the hospital rounded 7 days a week, 24 hours a day. One of them went through the organization and the nurses felt appreciated. We did involve the staff, in the design, as we heard earlier. That's key to get the users. Having increased staffing during the go live is important. And I cannot stress enough that you need to have metrics to be able to see, is it time to go back to the old ratio of what you had before? Don't just say because it's 3 weeks post go live and that's when we anticipated to go back to the old staffing levels. If your nurses are still having trouble learning how to use the system, the last thing you want to do is to put patient care in jeopardy. And so identify ahead of time what your metrics are that will then tell you that you can decrease the support. Now, what the nurses did ask me for was a phased approach. And again, I couldn't tell them that, technologically speaking, it's really hard to have two systems going. They said, why couldn't we have med-surg go live first, learn from that, take it to rehab, take it to ICU? I said, that's an interesting idea. You know the answer to that. So, recommendation for vendors in the room. And this really goes along with the previous talk. We need to have simpler systems that follow the way people think, follow the workflow. These multiple screens and multiple clicks are really hard to get that conceptual picture of where things are. And although the vendors love to have multiple ways to do the same thing, it drives the user nuts. What the nurses said when they gave me the detail about the education, they said, just tell me one way to do it. Don't tell me you can do it this way, you can do it that way. I don't understand this system anyway. I just want one way. So if there are multiple ways to do it, teach a standardized approach. They're going to figure out the multiple ways because these users are smart, they're clever, and they'll go snooping around. But teach one way, because you could click here, you could click there. They couldn't remember where they were supposed to click, and they couldn't find things. What do you need to do to mitigate the nurse distress? I mentioned it as I was speaking. Set realistic expectations. Actually, maybe I should say, set expectations to be worse than what you expect them to be. Because then the measure will be success. You definitely have to have additional staffing. You need to change the ratios. Care cards is what Grossman called them. They sent thank you notes and these care cards thanking the nurses. That really went a long way with those little meltdowns, and it helped a little bit with the major meltdowns. They provided food. It was acknowledgement that this is tough. And I'm sure that if you're not a nurse sitting in this audience, that what I'm saying probably is just as applicable to the physicians, to the respiratory therapists, to the pharmacists. I'm making it limited to nurses because those were the people who talked to me. And the management, 24/7, rounding in the hospital halls, was the nurses really appreciated that. And there's still a couple people that aren't real expert in using computers, so they did still, know your staff. Do you need to provide any type of computer basics? So with that, I think we have a few minutes for some questions. And okay, we have 5 minutes for questions. So I'd like to open it up if anybody has any questions for me. Yeah.
You said you had doctors who
Oh,
I'm Michelle. Oh, I'm sorry. I'm Michelle, and I was involved with our Go Live, and I was part of the nurse support team, so I was just wondering what.
oh, okay, good question, and I didn't mention it. We had a pretty typical setup. We had super users. Super users got twice as much education. They were the first ones to be educated. It was the super users who then proctored the workflow sessions, for the rest of the staff. And then during the go live, super users did not have a patient assignment, and they then walked the halls and would help people. And we kept the super users on as long as you kept them out of staffing. It was really a manager's decision when to put them back in, went over budget on that support because of the focus on patient safety. And then the super users are resource people even now, a year and a half later.
Yeah. So how much interface did this when we went Go Live, we had the super users and we had people called red coats. We had red coats from the company, and then I was the hospital red coat. So what I could do is go from my unit and go to the analyst and ask them, they were in a room, a control.
Right. And we had that, or Grossmont had that also, that the IT department, the educators, non-clinical, technical people were also walking the halls, and yeah, they had, I forget what they wore, but they had something that identified them. So it was a two-tiered kind of approach because the super user understands the workflow and the clinical implications, but if a change needed to be made, if there was a problem, then they would have to have that linkage to the analysts, and they had tickets and there were binders and there were meetings and things of that sort, yeah.
Hi, staying on the same line, I'm Don Sunk with AMN Healthcare. As it relates to the nurse staffing, did you pull primarily super users and additional nurse staffing from some of the other SHARP facilities?
Oh.
Did you use outside staffing? I'm just kind of curious, and then what kind of ratios you kind of came up with in terms of support? Thank you.
I don't know the answer to the ratios and the kind of support. I know that every unit had at least one super user, and I'm sure they had more than that, and I really can't answer that. Primarily, the Go Live support was the Grossmont staff, but because we had 4 hospitals that had gone live ahead of time, some of those staff people volunteered to work at Grossmont, and that was really good for the inter-hospital team building too. Now, some of the nurses, and I didn't have this in the results, said it would have been nice for the training, and talk about ideal, for us at Grossmont to have gone and worked at Memorial or Chula Vista, one of the other hospitals, so that we could use the system on a live patient. And again, that's a great idea if you can do it. Maybe it's something you could do for the super users, but yes, it's really expensive. And 1,625 nurses, the other hospitals couldn't absorb it. Money aside, they couldn't do it. Any other questions?
Dr. Fields,
Yes,
thank you so
Mr.
much.
Branning.
That was terrific. First, a comment, maybe tying with Dr. Cantor. Integrated systems been around since 1980. I worked on some of those because I'm really old. And I found it fascinating that at the end of the 1980s, everybody was saying, best of breed, that's the way to go. I had to fight consultants all the time. They went into that. So the evolution went the other way. They used to call integrated systems old monolithic systems so they could get their point across. Question for you, though. I was trying to mentally summarize what I was seeing in all your research, and it seemed like a lot of the negatives were about the implementation or because of the implementation versus the positives were all along the lines of the comprehensive data, the integrated data. Am I on track there?
Pretty much so. The 1 year post-implementation interviews, I can share some of that data with you, although we're not completely done with it. First off, I had trouble getting nurses to volunteer to be interviewed. I knew right off the bat that things had settled down. Because they weren't dying to talk to me. I trolled the halls. I came in on the night shift. And then, if I did not go to the units, I was not going to get an adequate sample size. So that's number one. 1 year later, they still value the data being available. So it's long past the edge. They've mastered the system, and they find all of the screens and all of the clicking disruptive to their thought process. When they have to go to another screen, it interrupts that flow of their decision making. So the data are available to them, but it's not in a view that is useful to them. So that remains 1 year later. So that goes beyond the implementation. And so the data is pretty different in this 1 year post go live. But the biggest thing that was resounding to me was the need to have a more user-friendly, iPhone type view, that we don't need 16 hours of classes for someone to be able to use it. Did I answer your question, Mark?
Thank you.
Okay.
One more.
Hi, my name's Nalani. I'm from the Eric Cohen Student Health Center at USC. I was sort of piggybacking on his comments. I was looking at your system, and I had a question about the increased usage of the different views. And to go along with that, there was also the increase in how many nurses had used an EMR before, as well as an increase of having difficulty finding things. Do you think there's a correlation with having difficulty finding things, or having difficulty with questioning the accuracy, that they're actually going into more views to see what's going on, or that they have the history of using the EMR, that affected the increase in using the different fields?
I think it's all of the above, meaning they knew how to find things in the old system, and certain things they knew they had to go to the paper chart because it simply wasn't available. So they had been doing this for decades. So they knew how to do it, and they felt comfortable with it. With the new system, so all of them were computer literate, they had been on electronic record. In the new system, they had difficulty to get that mental image of where things are. And so why was it so difficult to find the things? And if they couldn't find it, they thought it might not be there. There was no paper anymore, so they couldn't go to the paper. And I think we need to recognize that it's hard to find things. That when you have multiple screens and the scrolling and all of the stuff that was from the previous talk, when that happens, it is harder to find, and we shouldn't just train more. What we need to do is to design systems that make it easier to find it. That's the take-home message. So for the vendors in the room, you have job security.
So, Willa, I just have to ask, thank you for your presentation, but when I'm a nurse who grew up on paper, went to the EMR, and I felt my pulse elevating as you were walking through it. So is this right now, are you taking those super users, are they engaged with the company?
Yeah.
So that the display is meeting their needs? So that to me means the world, so that you've
Yeah,
taken that
people like you.
feedback.
Yeah,
Now they're working with the company and they're giving their feedback.
right. The vendors, I would think, every one of them is hopefully engaged with their user community, and that they're listening, and that they're forming partnerships to make it better. Because in that, if you remember from the most recent systematic review of the literature, so we're having the positive clinical results, but we still have the dissatisfaction. If we have dissatisfaction, people aren't going to use the systems, and they aren't going to use the systems to their potential.
Right.
And that's the real fear, that the systems are too difficult to use.
And the voice of the customer, right?
Yeah.
Being an advocate to marriage, because it can't be all the vendor. It has to be the complement of the two.
And as clinicians, we don't necessarily know the engineering and the programming. So we shouldn't be telling the vendor, you need to do it this way.
Right.
We need to be able to demonstrate the vendor what the type of workflow, what the principles are, and it's that partnership between the programmers, the engineers, and the clinicians. We both need to work together. It's not one versus the other. That's the other piece.
All right, thank you very much, Dr.
Okay,
Fields.
thank you all very much.
Okay, we got a 30-minute recess, so be back at 1:15. Say hi to the folks in the other room. Thank you.
Are they doing then barcode?
That's next.
administration? 'Cause
Yeah.
that would be your double check.
Yeah.
The other thing that I found with the